we are going to do a little bit of a deep dive on social cohesion. So these results that I'm going to be sharing with you here come from that same place that I just called your attention to on the Healthy People 2020 site. And it's a wonderful kind of summary of some of the evidence base for supporting programs that target each of those core areas. So in terms of social cohesion, like I think there may be some confusion about what do we mean by that. And so I thought it would be important to break that down, because of all of those core areas, of all of those components of the social determinants, I think this one is the one that might feel the most loosey-goosey to people, the most amorphous, or the most unclear, the least clear in terms of what its impacts could be on health, or what programming might look like that involves a social cohesion perspective or programmatic focus area. So the first thing that I wanted to point out is the fact that relationships are important for social cohesion. Social cohesion has three main elements that are relationship oriented or relationship based. One is social capital, the second is social networks, and the third is social support. So somebody who has social capital is somebody who simply has a lot of connections, or connections to the people around them, other people who can help them, basically. And we can contrast social capital with social networks. Social networks refer to the number of social connections that a person has and what the features or attributes of those social connections is, or features are. So can those connections, say for instance, get you a job, or can they get you an expedited appointment with a specialist of one kind or another? The third piece is social support. That refers to things like what kind of emotional support or logistical support can you expect from people in your social network. And that might be emotional things like the feeling that you get that somebody has your back if you get sick, or somebody just has your back, period. Or for instance, somebody can give you a ride to the clinic, that you have people around you that you can ask for that kind of help for. So these things have been shown in study after study to have an important impact on health. For instance, there's one study that's covered in that part of the website that uses 4 measures of social capital. And those 4 measures are an individual's perceived fairness of people toward themselves, perceived helpfulness of people toward themselves, whether they have group membership of one kind or another, maybe they belong to a church or other kind of social group, and then last, trust. And using those measures of social capital, this study found that all 4 of them were significantly associated with the risk of mortality. They also found that as income inequality increases in communities, going back to that Gini coefficient that I mentioned before, social capital decreases. So there's some kind of a relationship that I think is not well understood at present between whether or not there's a lot of inequality and income inequality in communities, and the extent to which people living in those communities feel a sense of having social capital that they can mobilize in times of stress. We also see in the social cohesion literature and studies of social cohesion a concept called collective efficacy. So that's important. It refers to how members of a community experience a sense of mutual trust with one another, and their own ability as individuals within their community to create change and exercise informal social control via cultural norms and things like that. We also see that social networks function in a particular fashion relating to health, and that's sometimes referred to social contagion. And so that can be related to both health behaviors and health outcomes. So lots of studies have demonstrated a social contagion effect. The ones that you're probably the most familiar with are obesity and smoking, or also alcohol use. So if your friend or one of your siblings or your spouse are obese, then your likelihood of becoming obese increases. And the same goes for drinking and smoking. So if you surround yourself with people who behave in a certain fashion and those behaviors have particular health outcomes, that's likely to be contagious and to affect your own patterns. We also see that high levels of social support will influence health outcomes, and those are influencing through both psychological and behavioral pathways. So for instance, we see in lots of studies that social support helps people do certain things like stick to a healthy diet, or it helps people reduce emotional stress over problems or challenges that they are experiencing. And numerous studies have shown how these pathways work and how they can affect biological functioning through the cardiovascular system, the neuroendocrine system, and also the immune system. So the data are out there, although people may think that it's not well established. In fact, there are many studies that show that these linkages do exist between these features or attributes of social cohesion and people's health outcomes. And we also see that there is a protective nature of social support, and that can be especially important for the experience of life and quality of life for minority or immigrant populations. So one study that's reviewed in this section of the Healthy 2020 website showed that higher levels of social support actually acted as a barrier against harmful health effects of discrimination among Mexican American women in California. So when we're thinking about social determinants of health and social cohesion, I think it's important to remember that the interventions can occur at multiple levels. So when you're thinking about ways that you could use this approach in, say, defining an intervention for your study or your population of clients of whatever kind, patients or other people whose lives you touch through your work as a public health practitioner, it's always good to recognize that you can work at the household level, maybe you'll work at a group level, a neighborhood level, or what have you, but having clarity about what level you're targeting your work at is important. We also see that work using this framework sometimes or actually frequently requires cross-sector collaboration. So that's knitting together the not insignificant energy and enthusiasm and sometimes resources from other divisions or departments within your county or within your state, maybe having to do with education, maybe pertaining to housing, and obviously pertaining to public health. In my experience, looking at interventions that use this social determinants approach, the really transformative interventions that I've read about or seen or experienced in person, they demonstrate really truly unconventional thinking and show program staff using relationships that they have with other stakeholders in the health system to mobilize these kinds of new ideas and energies that I talked about above when referencing other people that work for the county, maybe in health or maybe in education or housing or what have you. So knitting together the efforts of academics or lawmakers, public health practitioners, et cetera, is the name of the game. I, in this section, want to talk about rural seniors, and I also want to talk about the built environment a little bit more to help you guys understand what this framework looks like in some key interventions that I thought illustrate some of these programmatic emphases or the actual nuts and bolts of interventions that have worked. So the first one I want to talk about is the Baksu et al. 2012 study, and the references I'm happy to provide you after, along with slides. This is a healthy aging for rural dwellers research/intervention, which established the ways that healthy aging in rural places extends significantly beyond access to healthcare. Obviously, access to healthcare is certainly a factor for elderly or senior folks in our communities. But beyond that, there are other things that at least as powerfully affect their health outcomes, if not more powerfully affect their health outcomes. Those include housing, transportation, finances available to those seniors or elderly, lack of caregivers, and falls. Falls and housing are very much related. And so are some of the other things like financing and housing are very much related. When you think about housing, we're talking about how in rural places there is, generally speaking, an insufficient supply of appropriate housing for elderly people. That means one-story homes with everything on the same level, including bathroom and laundry, bedroom, bathroom, laundry facilities, and the kitchen, but also homes with safe entrances where elderly people are less likely to fall in icy conditions or in winter. Across the study participants in this particular study, what they saw was that condominiums were routinely preferred, but are rarely available. And some of the things that the study participants and the folks in the intervention were mentioning having to do with condominiums included things like living in a condominium and they had to downsize their life from a single family dwelling that they used to live in, which was considered to be beneficial. Ability to carpool works a lot better when you're living in community housing like condominium. Then they also mentioned that they could play card games or have other social interactions much more easily than if they lived in their single family dwelling as before. Like I was saying previously, with respect to transportation, there's a lot of stigma that seniors and elderly people voiced having to do with the inability or unwillingness to ask for help to get to places because of, people feel ashamed that they can't do that for themselves anymore. But a lot of the elderly, and this applies both to rural and urban population studied in these kinds of interventions, also lack a license, period, or they have self-imposed driving restrictions. So these factors really play a big role in the transportation piece of the healthy aging in place considerations and interventions. So in terms of what the solutions and practical interventions look like, the emphasis has been on programs that have what's referred to as wraparound care. So that's not just home health visits with clinical assistance, but in addition to the clinical or medical assistance that the elderly or senior folks might need, also things like helping with housekeeping, doing shoveling, or other tasks. So also by doing those other tasks, it means that elderly or senior folks are less likely to put themselves in a position where they're going to sustain an injury or going to have a fall that is going to wind up being, costly to them in all kinds of ways. Also, what we're seeing in interventions is some rerouting of funding at the local level, where funds are moved into prevention and social programs so that needs are addressed, which, if addressed, avert more costly medical and follow-up care in the first place. And snow shoveling is a great example of that kind of rerouting of funding associated with a hopefully decreased incidence of falls in icy or snowy conditions. I wanted also to bring your attention to built environment times education, or a crossover between, as I see it, those two core social determinants of health components. And bring your attention to this radon study. So this study was done in 2011 in 3 counties in Montana by Larson et al. In 2000, I think I already said it was in 2011. And so Larson et al. Did this study and published it in 2011. And it looked at the incidence of radon in the built environment in which we live. And so you may not know that radon is associated with an additional 21,000 lung cancer deaths annually. It is a contributing factor to lung cancer, particularly in rural places. It naturally occurs in the soil in many areas of the West, and many homeowners in this group will know because it's been brought to their attention by their realtor or their home appraiser when they're in the process of buying a home. So that may be on your radar screen if you have a certain kind of realtor, or if your home appraisal was professionally conducted and included those results. However, this still remains a significant housing issue for many rural populations. And what adds to this problem is economic segregation, which is increasing, I wanted to circle back to a point that Stephanie made earlier about the housing situation in Bozeman, which I understand from my friends who live there is dire. Housing is so expensive there, and it means that there is community gentrification in a manner that is not dissimilar to urban places that I've lived around the country, like what I saw happening in Berkeley, where I used to live, Berkeley, California, where as Silicon Valley took off, college students or graduate students or postdocs like I was at the time, you couldn't find affordable housing because people who were making a lot of money in Silicon Valley were snapping up all the available housing. And so we see the same sort of thing happening even in Montana towns or cities. Bozeman obviously comes to mind, but this is a problem in other places as well around our state. And I would imagine Colorado is just as bad, if not worse. What it means is that there's a displacement of lower income families to unincorporated parts of counties where there may be zoning law differences, or access to realtors who are maybe less complete, or maybe homes being sold, more homes or a higher percentage of homes being sold by owner, or what have you, where radon findings are not made available to people, or people just don't know. So this makes troubleshooting, or understanding and troubleshooting this kind of challenge very important for us as public health practitioners, especially in rural places in our state, Montana. So this particular study looked at socioeconomic variables and also what they called cognitive variables. And then there was there were interventions recommended based on the findings. So socioeconomic status in this case included income, whether the home was rented or owned, what the people's partner status was, if they were single or married, what have you, what their educational attainment was, and the number of children living in the home. And then for cognitive values, they had knowledge of radon et al., risk perception relating to radon exposure, and then self-efficacy. So there were questions asked that measured people's ability to behave in ways that would help them mitigate any radon exposure problems that they might be experiencing in their home. And so that circles us back to an earlier discussion today of the efficacy piece, self-efficacy piece of the social determinants approach. You might not think that self-efficacy and radon overlap, but in fact, the study showed that they did quite significantly. So in the results, they showed that in these rural counties, homes were in fact rarely tested for radon. Nearly half of residents had never heard of the harmful effects of radon, and that the more highly educated residents were 5 times more likely to have tested their homes than the residents of these counties who had less education. Self-efficacy was significant, but it was much less powerful, as it turned out, than education. Same for income. And this study really underscored a couple of things for me as somebody who reads a lot of studies of social determinants of health or interventions designed using the framework. One is the critical importance of education in affecting behavior linked with this particular housing and environmental hazard, because you wouldn't think necessarily that how much education you're getting at school is linked through radon to your likelihood of developing lung cancer, but lo and behold, it was. Second, this study shows an interesting intersection of 2 social determinants, being education and the built environment, playing together in a way that had an effect on health outcomes down the road. So in terms of solutions and practical interventions relating to this problem, what are the ways forward? So one is counterintuitively, like if you're a public health practitioner and you're focusing for whatever reason on radon, you might not think that supporting the education system like primary school or middle school or high school is something you need to think about, but in fact it is, according to these findings. So community health outreach programs that support parents with children of school age, and messaging, encouragement and nudges when home health visits are taking place to encourage children to stay in school, to attend school daily, to finish with their diploma, etc. And then keeping up with the health, nutrition, and vaccination programs that support attendance and persistence across the grades are little things that we can do as public health practitioners, or programs that we can design as public health practitioners that are very much in the wheelhouse of public health, but they have a knock-on effect or an associated effect in terms of keeping children of school age attending school and attaining those educational outcomes that are associated with greater self-efficacy and also greater likelihood of having your home tested for radon. Also, other practical interventions would be coordinating with other county departments about the significance of the radon problem in your local community, doing appropriate public health information based on the above, what other divisions or departments within the county tell you about the significance of this problem, and then outreach to home inspectors or realtors with flyers or other materials that will help educate them and their clients on the significance of radon and how to mitigate it. So I guess if I were you, I would be sitting here thinking, there's a lot. This is a lot. Where do I begin? And so I wanted to give you some very practical tips and pointers on where do you begin. For starters, I think that it has to be acknowledged that COVID-19 has revealed that our public health system has some key weak points. One is its operational funding. So our ongoing operational funding of the public health system in this country is not as strong as it could be. And we respond to this weakness by constantly looking to grant funding opportunities or similar. Not all of these opportunities focus program areas or types of interventions that are on the top of local people's list of needs. And if it's not at the top of your local stakeholders, your patients, clients, other folks that you're interacting with, if the program that the funding is available for isn't at the top of their list of needs, it can be a lot harder to advance the program forward, to get community buy-in, and so forth. So that is a weakness that I think needs to be understood and acknowledged. I think second, that to counteract those realities, the first thing that I recommend to people is getting stakeholder involvement up as high as it can be. So using participatory research methods for needs assessments, getting local people in your communities to help you design research projects, and then to conduct the research through community health workers or other kinds of individuals who are interested in helping out, can really shift the nature and completeness of your understanding of what needs are and how local people are prioritizing them. So identifying needs together with your communities, and the people using the CHIP approach already are familiar with what this can look like, but I think additional work can even be done beyond the CHIP approach. So this would allow, like, these kinds of participatory or very nuanced and sort of ethnographically rich understandings of what the needs are in our communities would then influence and inform our social determinants of health education, the flyers that we develop, outreach and person-to-person interactions with our patients and other clients or stakeholders like opinion leaders and so forth in our communities. And then the last point from this slide is that you don't have to reinvent the wheel. So you don't have to start from scratch and beginning to understand these things in your communities, because there are abundant tools. So here on this slide, and again, some people have asked if slides are going to be shared, and the answer is yes, a resounding yes. So you can use these links as you wish and at your leisure. But the screening tools that are listed below, the AAFP one, the Prepare one, that's not a typo, it is actually spelled with an A, Prepare, and the CMS one that I'm going to click on each of these individually and show you what they look at, are really great places to start to begin to get an understanding of what the social determinants of health kinds of needs are in your catchment area or in your population. Okay, so I'm going to stop this share and I'm going to click over to my other screen again. Which is this one here. Okay, So what I would like to show you is the AAFP physician guide. So the AAFP, this is American Association of Family Practitioners. So they came up with this thing that's called the Everyone Project, Advancing Health Equity in Every Community. So the first link that I provided here, that first bullet under AAFP, is this information here. It's a guide to using the tool. And when you complete this training course and have, listened to me talk about social determinants for our time together, this information will be very familiar to you. The second bullet point is the actual social needs screening tool. And you can see here that they have conformed very nicely to the social determinants model and have considered things such as housing, food, childcare, as somebody brought up, I think for Lewis and Clark County, but also employment, education, finances, personal safety, and so forth. You can see all the bits and bobs here. So this is a 2-pager. The questions only go to 15. So this is kind of a quick and dirty, but an excellent place to begin. Next, I'm gonna show you Prepare. This is, I think, one of the more commonly used ones that I've seen. And this is the protocol for responding to and assessing patients' assets, risks, and experiences. This is a very broadly understood social determinants approach. And in the Prepare website that I shared in the first bullet under Prepare, the first website has the guide. So you can see all the chapters here, from understand the Prepare model, how to engage key stakeholders, strategize the implementation process, and so forth. So this has sort of everything that you could ever want to know about actually unfolding one of these or executing one of these kinds of projects in your community. Okay, so then that brings me to the next window, which is the actual Prepare tool. So this is the second to the last bullet point on this slide. And this, again, is going to be quite familiar to you based on things I've shared with you so far today. So in other words, questions about family and home, money and resources, ability to meet different kinds of needs, social and emotional health, and so forth. So again, a short one, a 2-pager, only 21 questions. So, not that in-depth, really a quick and dirty, but an excellent starting place. Last is CMS's guide and tool, which can be seen here. This is for developed for Medicare and Medicaid people and or folks who are supported by Medicare and Medicaid. And so it begins with a bit of a guide. This is all in one single website. And it's, stuff about the screening tool, how it was developed, why it's important, and so forth. And then the screening tool questions are here at the end. And once again, reflecting or mirroring all of those core social determinants areas that we've talked about before. And this one is even, as you can see, slightly longer than the other two, going up to 26 questions. So this is a little bit more in depth, and I quite like it. I like all of them as a starting point, but I would really encourage you, if you're thinking of using a social determinants approach in any of the work that you do, to just spend some time on these websites and see what all what kind of information they're collecting, what is considered to be best practice by these weighty organizations such as the AAFP or CMS, and then think about the ways that you would want to tailor it or sculpt it to your community. Okay, so we are going to do our 4th poll now. So I'm going to stop sharing here and pop you guys over into my back over into my slides. And so, oops. Emily, you are on, my friend. So the last thing that I'd like you guys to weigh in on and then have a brief discussion about, because I see we're at 11:20 already. And let's hear what what you think about your communities. What are the primary factors affecting seniors or the elderly in your community or the client base that you serve, in terms of what are the most important social determinants of health for this particular demographic?
People are voting. Awesome. I'm more than happy. Kimber, there was a few comments in the chat box. One goes back a little ways about the marriage example, and then a gal recently posted. So just take a peek.
Okay, will do.
Just so you know. All
Catch
right,
up
we've
in
got
my notes.
19 of 22. So I'm gonna give you your little break. Are we doing breakout rooms again?
Very briefly, yeah, let's just do 5 minutes and then we'll finish up for the morning after. Yeah, so we'll do breakout rooms. It's now 11:22. Let's go to 11:30 in the breakout rooms and then we'll hear back from folks. So yes.
Cool, you should have your assignments again, folks.
Great, thank you, Em.
Do you want me to close the rooms?
Please.
Yeah, that one breakout room got special Kimber attention.
A little bit. I was hearing about the accountable model, or accountable health model, which I don't think I've heard of being used in Montana.
Oh, gotcha.
Are using it, yeah. Julie, have you heard of it? Julie Bear? Up here?
Yeah, Ver. I don't think in Montana. I used to live in Denver, so my head's kind of conflating things now.
Yeah.
I don't. You might check with Mountain Pacific.
Okay. You might have heard them use it.
I mean, I don't know, but they might have more information.
Yeah.
Do you have a contact over there?
I'm sure I know somebody that does. Yeah.
Okay.
Thank you. But if not, I'm going to email you.
Yeah, email me. I'm happy to introduce you to someone.
Thanks, Julie.
Yeah.
Okay, so Amy, would you mind sharing some of the things that you were talking about in your session? Because that was really interesting to hear. You've done quite a bit with rural and maybe even frontier seniors, elderly folks.
Sure. Yeah. So I was talking about we work with our local area agency on aging, and we do their assessments for in-home services, transportation, home delivered meals. And I'm located in one of our main towns, and our farthest town is about 2.5 hours away, which is, I would say it's probably frontier, probably 300 people in the town, but high senior population. And there are barriers to home care services, you know, because home care agencies don't want their home care workers traveling 2 hours for a, hour and a half, 2-hour visit. So that's one of our barriers. But I was saying, the communities have really come together and wrapped around food insecurities. But we have some volunteers that will go in and provide some respite and those types of things, but we run into the PPE barrier with making sure that we're safe when we're going in and providing those services. And then we also work with the Accountable Health Communities Model Project, which is providing social determinants of health screenings in our clinics. And we cover about 9,800 square miles, and we have 17 clinics in that 9,800 square miles. And if somebody does screen positive with 2 or more emergency room visits and 1 or more social need, then we provide care coordination. So we'll meet with the community member who's experiencing any sort of insecurity and go over what programs and resources are available, and then help them get access to that, to those resources. If they don't screen positive with the ER visit, if they're on Medicaid, all Colorado Medicaid members have access to a Medicaid care coordinator. So then we'll still go and meet with them and go over what programs and services are available to them and help them navigate that. But again, we run into the transportation barrier and the distance barrier. Luckily, we have care coordinators stationed throughout the region, so it's not as long of a drive, but it's still, we'll still be driving an hour to meet with somebody.
That's intense. And very similar up here in Montana. In fact, I was on a call not too long ago with some other folks across the country working on rural health challenges, and somebody was saying that their critical access hospital had closed in their state, which I think was Illinois or Iowa or someplace starting with an I. And they said, yeah, I mean, people used to have to drive 20 minutes and now they have to drive 40. And I was like, oh, we have to drive 4 hours. So these kinds of obstacles and challenges for big rural frontier states like ours, I think are very significant and also pretty poorly understood by folks in other parts of the nation who, when they think of rural, they're not picturing what we're picturing here in states like Colorado, Montana.
Yeah, and technology is our other barrier. You know, if you don't have internet access, then telehealth is out of the picture.
Yes, yeah. And what Amy and I, for the other group, were discussing was also that even if the connectivity is there and the bandwidth is sufficient to support video conferencing and what have you, that when you're dealing with interventions targeting senior elderly folks, the technical competence or savvy on that side might not be where it needs to be. And so that can be a barrier as well for those workarounds using the tele platforms. What about the other group? What did you guys come up with? You can see in the poll that Emily popped up on the screen for us here that economic stability and social community context feature for all people the most in our group, and that's very similar to findings going back to children when we did the poll for children. So that's interesting. Yeah, anybody from the other group like to weigh in?
Is Aaron on the line? Aaron, why don't you chime in this time? You had a lot to offer.
Colleen, what did you say?
Why don't you tell the group about what we discussed? You had a lot to offer.
Oh, I think that I'm just in two very rural counties here in the southwest corner of Montana, and I would say I couldn't see the polls. They weren't popping up, but the access to medical care and hospitals, in terms of maybe mental health, would be lacking for us here. Physical needs can mostly be met, but mental health care needs, especially right now during coronavirus, I would say are lacking, and especially in a county or in a location where we have like 9 months of winter. So the things that you typically recommend people to do to take care of their mental well-being would be a little more difficult for an elderly person to get outside and get that fresh air and that exercise.
Yeah.
Bad roads might limit the social support that they would get if they are residents in a nursing home. So those are kind of the things that we're running into here. So the thought that I had was maybe engaging our youth and helping them build a rapport with the elderly here in our community by providing some type of companion program. An incentive for the youth could be that it would maybe count as volunteer time on a college application and work through it that way.
I love that. So did you just get that started?
No, we haven't. We just talked about it right now.
Oh,
but I did take notes while we were talking. So
I love it. Okay, you'll have to keep us informed.
A great group discussion, and I think everybody got a lot of ideas.
Thank you. Well, I'm minding the time and wanting to make sure we finish by the promised time, even though we did get a little bit of a late start because of tech. But let me just share my screen again and we'll segue into my final set of slides. So I just wanted to start out by oops, this big. Sharing these data from, again, going back to the American Hospital Association, which looked at how many hospitals and health systems are already using this approach. And I was quite excited to see how common it is, even a few years ago, for hospitals to be seeking these kinds of partnerships in the community. On the left here, we can see what sort of program is being pursued. Now, I understand under the ACA that hospitals are required to have some kind of community outreach program. So I would imagine that that is an underpinning to some of these numbers, which are quite positive, as you can see here. But beyond that, you know, from this, the last slide with a graphic from this organization, but where they sort of end is on these points here, which really echo some of the things that I myself have shared with you. Know and engage with the community, gather data, you know, get the surveillance done so that we know what these factors are looking like in your community, the ways that your community differs from others. Organizational and internal engagement strategies with other folks that you work with within your division or department, and encouraging those people who are doing budgeting and the finances to integrate social determinants, exploring funding options outside of the operational budget, and establishing measurement strategies and evaluation tools that are appropriate. What I wanted to do next is talk about a handful of studies that were described in 2008 in the Journal of Public Health Management. And these are what I consider to be things that form the evidence base. These are features of social determinants of health influenced interventions. And the first one I wanted to talk about is the anticipatory care model. And this is the only one from another country that I'll mention, but this was done in the UK, and I wanted to mention it because I thought it was kind of important perspective. What the physicians in this group decided was that in order to comprehensively care for the health of their patients, that they needed to fundamentally change their relationships with their patients, meaning increasing their engagement across the board. That meant in their case, increased time with each patient, intense follow-up, reaching back out to patients at home after appointments, long-term relationship building with people that they serve in the community over many years, staff expansion to provide comprehensive care. So hiring more people. And what was the result of this intervention? Well, after years of changing their care modality, what they found was lowered blood pressure levels among their hypertensive patients, lowered smoking rates, and lowered mortality compared with the neighboring community where the physicians group had not embraced this approach. So these interventions that I'm going to be talking about for the final half hour or so, or less, I've broken into interventions within the healthcare system and upstream interventions. So the other intervention within the healthcare system that I wanted to describe is the Nurse Family Partnership Program that was undertaken in New York, Tennessee, and Colorado. This was aimed at low-income adolescent or unmarried pregnant women, and it was a home visit program. It focused on reducing smoking, alcohol, and illegal drug use, and increasing prenatal care. And those visits continued after birth, and they provided support beyond those sort of clinical considerations to encouraging people to seek and obtain economic self-sufficiency through employment programs, to get good and comprehensive childcare, and to encourage people to do more future planning, and also to give support of these kinds that I've described so far to other caregivers within the household. So not just mom or dad, but also grandparents, aunts, uncles, siblings, what have you, people who are also contributing. And the result of this intervention was improved health-related behaviors during pregnancy, lower rates of pregnancy-induced hypertension, reduced rates of child abuse, longer interbirth intervals, and longer partnerships with their partners, and lower reliance upon welfare and food stamp programs. So they actually followed up with a cost-benefit analysis of this particular program, the Nurse Family Partnership Program. And their analysis showed there was a return of fully $17,000 per family assisted by the program for the states that the program was functioning in. And that was measured in terms of the knock-on effects of reductions associated with crimes, substance abuse, child abuse, and neglect, and also domestic violence. So, you know, again, the holistic, multi-pronged approach you can be seen in action here, but also that the effects have rippled out across these other areas that end up being costly, not just to the healthcare system, but also to the legal and judicial systems and so forth. Oh, there was one last program that I thought was really cool that I wanted to share with you. That was an intervention within the healthcare system. This is a medical legal partnership model. I just loved this one. And it occurred at Boston Medical Center. And the model has taken this approach where they integrate on-site lawyers into the specialist network for primary care referrals from the pediatrics practice. And so the premise was that low and moderate income families face serious legal challenges that affect their ability to interface effectively with the healthcare system, which I think we all know is true. This adversely affects quality of life and ability to manage chronic illness. So there were legal areas that were commonly a challenge for this client population, and those would be legal challenges associated with housing, immigration status, or disability. But in addition to that, income support, so employment law, access to health insurance and gaining access to insurance, and then education access. And so the results of this intervention, unlike all the other studies I'm going to share with you, are as yet unknown because this program hasn't yet been rigorously evaluated. But from my reading on it, I believe it shows promise for improving care and also the management of disease, and the authors concluded the same. And I really think this is a very innovative approach. It's a wonderful demonstration, in my view, of an initiative for wraparound care that is truly multi-pronged. So I would encourage you in your thinking, like maybe there's a group of professionals in your community that public health practitioners don't conventionally interact with. In this case, it was attorneys. Maybe in your case, it would be another group of professionals. Like I mentioned before, maybe it would be realtors if you have a radon problem, or home appraisers, home appraisers, or I'm forgetting the name of the other people that come and look at the home right before you're going to buy it.
Inspectors?
Yes, your home inspectors. So maybe there are, you know, depending upon what health needs affect your community, the general rule here that I'm trying to convey is that in terms of fund seeking and grant seeking, those initiatives that you craft and describe or propose that show this kind of initiative, this kind of innovation, and knitting together the enthusiasm and energies of people from, you know, slightly outside of the public health box, I think will be extremely well received. Okay, upstream of interventions, there were a few that I wanted to describe. The first one was focused on improving neighborhood conditions. And this one was a program called Moving to Opportunity. It was undertaken in 5 different states. And this was a fair housing demonstration project. So it targeted low-income, mostly minority residents. These were randomly selected and from high poverty neighborhoods, and then assisted in a move to a lower or to a higher income neighborhood or less poor neighborhood. So people who were in either of those 2 groups were randomized. And the study was aimed at comparing the mental health outcomes of those who did and did not move. Results of the intervention were that 2 years after initiation, those who moved had better overall health, less substance abuse, less violence, and higher rates of employment, and less reliance upon welfare programs. There are lots and lots of other interventions out there that you can read about. Or some of the things that are commonly pursued, as mentioned in a previous slide today, would be things that improve traffic or sidewalks, for improving neighborhood conditions, improving landscaping, improving lighting, strengthening windows on buildings in the neighborhood, building gardens, and that sort of thing. Those are all very common in these kinds of interventions. And many interventions of this kind have demonstrated real results in terms of health outcomes, including things like significant reductions in anxiety and depression, but also community building results like higher levels of trust in neighbors, higher levels of optimism, and higher levels of future thinking, which all, as you would imagine, would be related with those mental and behavioral health outcomes. There was a study, an intervention, and a study associated with it called the Great Smoky Mountain Study / intervention. This was an interesting natural experiment. This was an impact of income supplementation on levels of mental health for children in a population of American Indian people in North Carolina, where a casino had been built and where the study participants had received additional income as a result of that casino going in. And then also the children in the study were recipients of trust funds. So the supplemental income averaged $6,000 a year per household by the end of the study. Not a huge increase in income. However, in addition to new job opportunities associated with the casino, like at the hotel and what have you. The results of this quotes intervention, because it was really, it was an actual experiment, but they tracked it over many years. Children and families with supplemental income had declining rates of deviant and aggressive behavior. And by year 4, their level of psychiatric symptoms was comparable to those of children from families where poverty had never been experienced. Other interventions that are like this one have shown very similar effects, where job support alone, specifically employment-based anti-poverty programs, are shown to have a positive impact on children's school achievement and on children's motivation and children's social behavior. And that's been especially true for boys aged 6 to 16, which I think is remarkable, being the mom of a boy. Those are tough ages. And so when kids are struggling in school on top of experiencing disruptions at home because of unemployment or lack of income, we all understand, I think, the related effects. I also wanted to talk about early childhood academic enrichment programs, which are another kind of social determinants of health program that focuses on interventions in the school setting. So the Perry Preschool program selected 123 African American children. They were randomly assigned to the intervention and control groups. And the intervention group had a simple intervention. The teachers held in 1 extra daily class per day, or I guess that's redundant, 1 extra daily class with the students in the intervention arm. And they also had a weekly home visit opportunity for all of those children at home. So the results of the intervention were that by age 40, the intervention group had higher graduation rates, higher socioeconomic status, lower lifetime rates of crime and welfare dependence. And though health outcomes themselves were not evaluated, I would say that the SES finding, the socioeconomic finding, is significant in terms of its ripple effect on health outcomes. But other interventions that are detailed in this same paper, the 2008 meta-analysis, of very similar interventions in North Carolina and Illinois, followed children through ages 19 in the one study and 21 in the other, where the interventions were very similar to the Perry Preschool program. The intervention groups there had significantly lower rates of depression, lower rates of disability, lower rates of crime, and also higher educational attainment and health insurance rates. So again, we as public health practitioners don't necessarily envision ourselves working in the public school system per se, or in a preschool system or program per se. But in the ways that we can work in our offices or with our clients to support parents enrolling their children in preschools, or reaching out and giving that ourselves, that personal touch, that support, those follow-up calls, that feeling that we can give our clients and our patients that we care about them. The impact is profound. And as I said, the intervention in the case of these studies that I just mentioned here on early academic enrichment were not complex. They didn't have a lot of bells and whistles, but it was the mere act of the connection and the fostering of that, cultivation of that relationship between those teachers over years with those families was the thing that seemed to have that positive effect. All right, ways forward. So experts recommend that for programming that integrates a social determinants of health approach, you should be doing the following. One, you should consider the available literature on interventions that are effective. And I got you started a little bit in this last little bit of our time together today on what some of those studies look like and what are some of their findings. Most of these interventions are very thoughtfully designed in that they are tailored in key ways to the local population that they're serving. And a lot of them don't have a lot of fancy bells and whistles. It's the personal touch that seems to be the thing, both in the physician group in the UK that I mentioned, and some of these early childhood programs that I talked about as well, that is playing such a huge role. Now, these interventions and solutions are not boilerplate. It's not a one-size-fits-all kind of situation. That it calls upon intervention designers to know and understand the cultural and social, economic, et cetera, landscape of our target communities very well, and to be proud that we do know them, that we took the time, that we bothered, that we've come to understand our clients in the way in the best way that we can. Also, we need to understand that non-medical interventions are likely to be differentially effective for different health indicators. So like improvements in education might have a big impact on health outcomes where knowledge is important, like fertility management or radon, but improvements in material resources are likely to have a big effect or impact on prevention or management of some illnesses, like the management of physical disability, for instance. Last but not least, I really want to encourage you to use the Healthy People 2020 social determinants of health objectives to frame your interventions going forward and you're thinking about them. So this is going to be helpful to give your intervention some structure, but also in terms of seeking funding and technical advice down the line. So the last thing that I wanted to do was bring you over to the Healthy People website. So I'm going to stop sharing that screen and I'm going to share this other one over here and bring you to this last box. Can everybody see what I'm, the healthypeople.gov site? Super. Okay. So what we have here are in green font. Oh, so the green tabs along the top. You want to click on objectives. In the green font is sort of the core social determinant area. And then it delineates those, say, under education or health and healthcare into further and further specificity. I wanted to bring you down to this one right here, DH-17, just as for example. If you click on this, this is increasing the proportion of adults with disability to get sufficient social and emotional support. And there are all kinds of important things here. There are some baseline data, and it shows when those data were collected, what the target is, what is the target setting method, what are some typical data sources like BRFIS or CDC data that are used to collect the information that can show that you're having an impact or not. And then other useful things like mapping the state level data for the objective, details about the methodology and measurement of initiatives or interventions that go toward meeting this objective, and so forth. So I would really encourage you to spend some time kind of clicking through all of these tabs to familiarize yourself with what is being done in other places, what the metrics are that are being used, what are the methods to collect those data, and so forth, because that can really give your proposal some structure, and you're thinking a framework that helps kind of guide you forward. And I don't know about you, but the way my brain works, I always like to start with somebody else's structure. It really helps. Okay, So that brings me to our very final slide, right at noon on the nose. And wanted to thank you for attending and participating so collegially in our discussions and sharing some of the things that you all discussed in those breakout rooms. We would love for you to fill in the evaluation for today's training. And Emily will pop that link over into the chat box so that it's easy for you to click on it. Emily, could you also chime in and tell people what's the easiest way to get the slides? Should people contact you, or will you just share them automatically with everyone?
I will share them out. And so, like I said, the link to the evaluation is in the chat box. So please take a moment. We certainly use that information. And once I have I'll get the slides and I will send those out along with the link again. So if you don't have time to do it now, you can. So you will have them this week.